Welcome to session 3 of the Public Health Surveillance course. In this session, we'll talk about the notifiable diseases and events and other sources of information for public health surveillance. We'll go through different sources of information for public health surveillance and focus in more detail today on notifiable diseases, conditions, and events, and the use of registries for surveillance purposes. We'll also talk briefly about other sources of information for public health surveillance, vital registration, administrative sources of data, surveys, and intersectoral data sources. But most of these sources will be covered in more detail in subsequent sessions. With regard to notifiable diseases and conditions in the United States that are reportable by providers and labs, who decides if the disease or the event is reportable? Well, legal authority and regulations for disease reporting are determined at the state and local levels where most laws and regulations around public health surveillance are implemented. And the way that it plays out is that CDC, who's a major stakeholder in public health surveillance at the federal level, CDC collaborates with an entity called the Council of State and Territorial Epidemiologists, or CSTE. And CSTE is made up of epidemiologists from state and local health departments. CSTE makes annual recommendations about which diseases and conditions should be reported to CDC and published in the MMWR. And once those recommendations are made, states and localities, including health departments, then decide whether and how to implement CSTE recommendations. They review the recommendations and decide whether to make something reportable in their jurisdictions, which could involve introducing new laws to require reporting or changing regulations to enhance existing reporting requirements. So making a disease or health condition reportable is not something that's decided at the federal level, for example, by CDC or Health and Human Services. It's something that's done at the state and local health departments in consultation with CDC or with CSTE. And ultimate legal authority around reporting requirements rests within states. So ultimately, when you see statistics in federal publications like those from the National Notifiable Disease Surveillance System and CDC Wonder, it's important to recognize and remember their origin. They all come from state and local health departments and from surveillance systems that those health departments put in place for these notifiable conditions. And then they ultimately make their way from local health departments to the state health departments to the CDC, where they can be compiled in national statistics. This slide shows recent information on the number of notifiable diseases and conditions and events globally for the US, New York State, and New York City, just to give you a sense of the universe of things that are reportable. Globally, there are about 24 conditions reportable by United Nations member states to WHO, and you can see them listed here. A lot of them are deadly infectious diseases of epidemic and pandemic potential. In the US, there are about 91 notifiable conditions, which stem from the CSTE recommendations. New York State has 75, and interestingly, New York City has more than New York State. There's 94. This is because as a locality of New York State, New York City must follow all of the state's laws and regulations, but they can choose to regulate and require reporting beyond what the state requires. And so all of these conditions are reportable by healthcare providers, and most are also required to be reported by laboratories. So an important caveat to the reporting requirements to note is that there are 94 specific diseases that are reportable in New York City. But in NYC's health code, there's added language that says, in addition to these 94 things, any unusual disease cluster or suspected outbreak of illness is also reportable. And this language allows the city to be able to invoke surveillance with new reporting requirements when there are outbreaks of any disease, which would include clusters or outbreaks due to new and emerging infectious diseases, for example, those things that would not necessarily otherwise be reportable under the health code of the city or state because it requires regulations. So this language is really important for pandemic preparedness because it requires a pandemic response requires rapid and intensified reporting requirements that need to be put in place before there can be laws or regulations that authorize the surveillance for a specific new pathogen, for example, which may, by the way, take a while to identify. Lastly, in the US, where there is regulation, there's a regulation called HIPAA. This is a regulation that protects the privacy and unauthorized sharing of patient health information. We have this regulation, but the main point to take away here is that HIPAA doesn't apply to public health surveillance activities, and it cannot be invoked by providers or laboratories as a reason not to comply with surveillance reporting requirements. This slide shows a table of reportable conditions and events for New York City, so you can get a sense of what they are in our locality. They're organized into 3 groups, A, B, and C, and these groups relate to the timeliness with which providers and laboratories are expected to report to the health department. Group A includes conditions that providers must report immediately without waiting for laboratory confirmation. Group B includes those conditions that must be reported immediately if the case is a food handler or someone else who could be potentially involved in the ongoing spread of infection to a large number of people. Group C includes those conditions that must be reported within 24 hours. Of all the reportable events here, you can appreciate that they are primarily infectious diseases, but there's also things like animal bites, drownings, and window falls included in Group C. How do providers and labs and other entities report information to health departments? Usually they're submitting it via some kind of structured reporting form, and ideally this is not a separate reporting form for each notifiable disease or condition. It's better for it to be a single form that can be used to report many different conditions. Increasingly, provider reporting is done by electronic means, and increasingly in New York City, at least for labs and providers, there's the ability to submit entire data files of reportable events, so not just one person at a time or one report at a time. This is useful, for example, especially for laboratories or healthcare providers that diagnose many people who have a reportable condition each day. So here's an example of a form that providers use to report a notifiable event to the New York City Health Department. It's called a universal reporting form because it's possible to report different notifiable conditions and events using this form. It's not specific to any one condition. And the language, note the language at the top instructing providers that they need to immediately report a notifiable disease or condition, an outbreak among 3 or more persons, or an unusual manifestation of any disease or condition, or any newly apparent or emerging disease or syndrome, by calling directly the number provided for the provider access line. There's also a link for providers who want to report electronically via a system called NYC Med. And next, you can see a place to provide information about the patient, including demographic and identifying information, housing status, whether the patient was admitted to the hospital, the date of diagnosis, and when the patient's symptoms started. And that symptom onset date may differ from the diagnosis date, usually does. Then there's a section near the bottom right here that allows the reporter to specify whether the case is suspected to have resulted from a healthcare associated transmission, or to provide details about whether or not there was recent foreign travel. The next section of the universal reporting form includes information about who's reporting the case. Importantly, the name of the person reporting the disease is not necessarily the diagnosing provider. It could be, instead, for example, an administrator at the hospital or healthcare facility. There's a place for their name and contact information, as well as that of the healthcare provider. There may be specimens associated with a case being reported that were sent out for laboratory testing. And in that case, even if those test results aren't ready yet, the provider can specify the details on the laboratory where the specimens were sent, so that the health department can follow up with lab to access the results, or expedite them, or maybe obtain specimen that's left over after testing for additional testing that might be needed. The next section includes a long list where the person reporting the case can just check off the specific event or condition or disease that they're reporting on. And depending on which box they check, there may be special instructions to follow, or additional details that someone reporting can provide that are more specific to the condition, the specific condition. The ones that require immediate reporting by phone to the health department are indicated clearly by an asterisk and also highlighted in green. And although providers in New York are required to report new diagnoses of HIV or AIDS, they're not supposed to do that using this form. There's a separate reporting process and form for HIV that's required by New York State Health Department regulations, and that's going to be covered in more detail in our next session. At the bottom of that page, you'll see a section where potentially relevant epidemiologic information related to the risk of epidemic spread of infectious diseases can be captured, including occupational information about whether the patient works in childcare or food services or healthcare, correctional facility or nursing home, or in a job where they may have contact with animals, which is relevant, for example, for H1N1 and zoonotic diseases. There's also a section about whether the patient resides in a congregate setting where there's risk of epidemic spread, such as a nursing home or a correctional facility. The next section of the Universal Reporting Form deals with environmental conditions, such as those resulting in animal bites, drownings, or window falls. Below that is a section devoted to capturing information on poisonings, including the types of poisoning, the source of the exposure, the mode of the exposure, details around the vital signs of the patient at the time the report was made, and then any treatment that may have been administered by the provider in response to the poison exposure. The next section on the form is for reporting cases of tuberculosis or TB, with details around the type of TB that is being diagnosed, any laboratory testing that has been done, as well as other diagnostic testing and treatments that may have been initiated. The last section of the Universal Reporting Form is dedicated to sexually transmitted infections, or STIs. In addition to indicating which sexually transmitted infections are being reported, there's a section that asks providers to give details about whether or not the patient's sex partners had been notified and whether or not there was any treatment provided to the patient's sex partners that may have been exposed to the STI. There's information requested here about the gender of sexual partners, which has epidemiologic relevance. So the last few slides I showed you are the Universal Reporting Form used in New York City by providers or their designees to report notifiable conditions, diseases, and events. But we've also discussed that laboratories have reporting obligations as well. And so it's important to remember that all medical laboratory tests are initiated by a healthcare provider. And it's those healthcare providers that decide which test to order for a patient, and then they send the specimen or specimens to a lab for testing, along with what's shown here, which is a laboratory requisition form. It's the form requesting specific tests along with information about the patient. So to understand the kinds of information that gets reported from laboratories, it's important to understand the types of information that goes to a laboratory along with the specimen from the healthcare provider. So each lab has its own requisition form. I'm showing you one for a common national lab called Quest Diagnostics. But this can be slightly different from one lab to the next. But this example, you can appreciate it that it really only captures basic information here, including the patient's name, gender or sex, and the date of birth. And this information is required by laboratories for them to test the specimen. They won't test it if they don't have that basic information. But there's not really much else about the patient that's required to be on this form. The form also requests information about the ordering physician, information about billing and insurance, and very importantly, the specimen collection date and the specific laboratory tests that are being ordered, which you can see with the check boxes on the form there. But that's really about it. And laboratories, they have information on what comes with each specimen. So it's important to know here what is not on the laboratory requisition form. Much of the information we want as epidemiologists is not here, including symptoms, date of illness onset, information on risk factors, and things like that. And so this in turn means that laboratories really, even if they wanted to, can't report much information to go alongside the results of their laboratory tests beyond what comes in on these requisition forms. So this is another opportunity to highlight, why we need both laboratory and provider reporting. The other thing I want to note is that a requisition form here is from Quest, a national commercial lab with locations all over the country. Specimens submitted by a healthcare provider in New York State might be tested in New Jersey, for example, or another state. How does the health department in New York get these reports? Well, commercial laboratories need to be licensed by each state health department in order to be allowed to test residents who live in a given state. And as part of this licensing process, each state can impose reporting requirements as a prerequisite for receiving and maintaining a license on the laboratories. So for a New York City resident who has specimens that are sent to a laboratory in New Jersey, that laboratory must be licensed by New York State in order to perform the specific laboratory tests being requested. And when they perform those tests, they're required to report the results to the New York State Health Department. If they don't, they can be fined or they can lose their license. And so that's how a surveillance system can capture information on notifiable laboratory tests, even when the laboratory is outside of the state's jurisdiction. So while it's the intention of laws and regulations of each state and locality that every case of a reportable disease or condition be reported, the reality is often otherwise. For rare, serious diseases of public health importance, such as rabies, plague, or botulism, the percentage of cases actually reported may approach 100%. On the other hand, for some other diseases that are things like aseptic meningitis, completeness of reporting is found to be as low as like 5%. So we saw this reality in the example of shigellosis from the last session. And since you can't expect providers to report cases unless they actually see a healthcare provider for the condition, the green line here is really the minimum number of cases we could expect to have reported to surveillance. But even when a patient with Shigella sees a provider for their symptoms, that patient might not be diagnosed as having Shigella. They couldn't be correctly reported as a Shigella case if they were not diagnosed or if they were misdiagnosed. What else could go wrong? They could be diagnosed, but just not reported by the healthcare provider, of course. And on the laboratory side, providers may not always order a laboratory test for the condition that they're diagnosing. They may be confident enough to make their diagnosis without obtaining a laboratory result, or the laboratory test might not really influence anything about how the patient is managed, so there's no point in ordering a test. We'll talk about the different things that can affect the completeness of case reporting on the next few slides. So now you have a sense of the kinds of surveillance-related information that can come from provider reporting and then laboratory reporting. And now you have a sense that the completeness of information reported can sometimes leave a lot to be desired. So what does the health department do when they're getting both provider and laboratory reports, but they still don't have all the information they need for surveillance? They can do outreach to specific providers and labs when this happens. This could involve a review of records to see if information is even available to be reported, and if it is, they can gather it as part of outreach activities. Of course, this is more resource intensive than just doing traditional passive reporting. And another strategy is to supplement passive reporting with a degree of active surveillance by health department staff. Each source of information can really be complementary. Next, I want to cover a few things about registries that are used in in surveillance for notifiable diseases and conditions, including a worked example. For notifiable diseases and events and conditions, surveillance systems often create or rely on something called surveillance registries. Surveillance registry is a running list of all people who are reported with a particular notifiable disease or condition. And of course, reportable conditions, most of that information comes from providers and labs. Registries of notifiable events are basically where all of the reported information on cases resides, and it's updated with new information received by health authorities at any time. So there are different kinds of surveillance registries out there, and some of them can be population-based, which means they cover the entire population of a jurisdiction or state. These can include registries of deaths and births, which we also call vital registries. And they can include reportable diseases and conditions like infections or cancers, and things like an event that's not a disease or a condition, such as there can be an immunization registry that tracks the vaccines that were delivered, or an exposure registry such as New York State's World Trade Center registry, which is for people who were directly exposed to the World Trade Center attacks. People in these registries can then be followed forward in time to observe a variety of health outcomes that might be relevant to an exposure that they all may have in common. Registries can serve as the primary basis for a surveillance system, or they can also complement a surveillance system, and we'll see examples of this on the next few slides. I'll go through an example of a surveillance registry for a notifiable disease. So all the next few slides are going to build on this schematic of a surveillance registry that receives reports for a notifiable disease from providers and labs, and we'll use it to consider different kinds of case reporting scenarios. As you can see on the schematic, providers and labs each report to the health agency, and then the health agency processes that information. They may do some additional investigation of potential cases that are reported to them. Ultimately, the surveillance registry is updated with all the information received, whether it be with an initial report of a new case or with updates to information on previously reported cases. I've included a dotted line here, which is the link between providers and labs, and that really reflects the link that where providers are reaching out to labs to request testing on some of their patients, and then laboratories report back that information on the test result to the providers. So this is a bare bones conceptual schematic of the flow of information into surveillance registries. Let's build upon this concept a little more. Suppose now on the left we have cases A through N who have a notifiable condition, and they seek healthcare from healthcare providers. Assuming all goes well, providers would correctly report the diagnosis and then report those cases to the health agency in a timely manner. In this scenario, while cases A through N sought healthcare, if you look at what was reported to the health agency by providers, it only includes cases B through F. And in the surveillance registry, just looking at those cases that were actually reported by providers, we're only seeing cases B through F. Case A is not reflected. It may be that this particular notifiable condition, the agency also conducts active surveillance. And that is, they're visiting or doing outreach to healthcare providers to identify new cases of the event under surveillance. And here you can see that active surveillance uncovered some additional cases, cases G, H, and I, that were seen by providers but not reported. So this is how those cases now make their way into the surveillance registry. Next, consider the information that's coming from the laboratories. Remember that providers may or may not order laboratory tests for any given patient. And you can see that providers here ordered tests only for patients B through K, but not for patients A through L. The labs do testing on the specimens, and that might include even doing multiple tests on the same patient on the same day or on different days. So you can see, for example, here in yellow at the bottom, how we have the 3 different laboratory tests reported by labs for patient C, 1 for patient D, 4 for patient E, etc. And this results in the agency becoming aware of cases C through K via laboratory reporting. Well, what about cases A and L? It could be that even though providers reported case A to the health department and the health department processed case A, that case didn't make it into the registry because of errors that can happen even within health departments. Things can really go wrong at all levels of this process, and it may be that case A was incorrectly determined to be a duplicate of another case that was previously reported to the surveillance registry, and so case A doesn't show up as a unique person in the surveillance registry. Cases J and K were not initially reported by providers or identified via active surveillance, but they were picked up through laboratory reporting. And cases L through N are completely missing from all 3: provider reports, active surveillance, and laboratory reports. So we're going to have a whole session devoted to vital registration coming up, but I just wanted to use our example here to give a quick illustration of how vital registries can be used to supplement surveillance registries. So case A was reported by providers, but is not ultimately reflected in the registry. And cases L through N were not reported by providers, and no lab tests were ordered on them, so they couldn't be reported by labs. But many surveillance systems do occasional matches with other registries, including death registries. So in doing these matches, in addition to ascertaining the vital status of all the cases that are reported to surveillance, it's also common practice to look for people who have died from the condition under surveillance who may have met the case definition, which is another means of case finding. It's obviously not ideal if death registry matching is a major source of case finding for the surveillance system. You want to find them earlier, but it does let you see where there were missed cases and where people should have been captured earlier or fell through the cracks in your surveillance system. You can then go back and troubleshoot and identify gaps in surveillance and case finding that may need to be addressed. This example is also meant to give you a sense of how the information can flow and how getting information from passive provider reporting, active surveillance, and laboratory reporting can help increase the completeness of surveillance registries. So it also highlights where things can go wrong, which is pretty much at any step in the process, as I mentioned. So the redundancy we've discussed that you can build into surveillance systems and reporting can also be very important. Ultimately, cases A, M, and N were not reflected in the surveillance system, likely because of data errors and incomplete reporting and imperfect active surveillance. These cases represent 3 of the 14 cases that should have been captured, meaning that the surveillance system captured 11 of the 14 cases that occurred and should have been reported to surveillance, for a completeness of 79%. We'll touch briefly on administrative data as a source of information for public health surveillance today. This is another topic which we'll be devoting a session to later on in the course. So administrative data collection includes data that are collected for purposes other than public health surveillance. They don't exist for the purpose of monitoring health status or health outcomes. These data are collected for other purposes, for administrative purposes, administrating some kind of program or process. So for example, hospital admissions logs or hospital discharge data systems really use data that exist for the purposes of billing, not for public health surveillance, but they can be useful for the purposes of public health surveillance. Laboratory information systems, healthcare claims data, and pharmacy sales data are databases that are also in place for purposes other than surveillance. But of course, you have to consider whether or not one of these data sources will be useful for the purposes of surveillance based on its availability and usefulness for achieving the goals of your specific surveillance system. So here's an example of how hospital discharge survey data can be used to monitor trends in diabetes hospitalization across the US. And you can get a sense of how tracking trends in hospitalizations for diabetes can be useful because it allows you to understand groups for whom the situation may be worsening. In this case, the administrative data on hospital discharges for diabetes suggests that there was an increasing trend in diabetes hospitalization over time, with a widening gap between males and females. Administrative data on hospitalizations in New York from the Sparks hospital discharge data system are routinely used to get a sense of what some of the health priorities might be in specific neighborhoods around New York City. Here we can see how the rate of avoidable hospitalizations differ among residents of Central Harlem compared to all residents of Manhattan. These kinds of data are really useful for community advocacy, to advocate for resources, and also to gain insights about what kinds of public health programs might be needed for place-based public health initiatives. And here's a list of some national examples of administrative data. If you're interested, you can follow these links to learn more. Okay, so surveys are another important source of information that can be used for surveillance or to complement surveillance activities. They can be components of surveillance systems, or they can serve as the basis for the surveillance systems themselves as well. And one major strength of surveys is that they generate estimates, or they can generate estimates that are representative of the general population. And since they involve talking directly to individuals or interacting directly with individuals, surveys are capable of providing types of information for assessing the prevalence of diagnosed health conditions and risk factors, among other things. They can gather information that you usually can't get from other data sources like knowledge, attitudes and practices, or behaviors as they relate to certain health outcomes that might be of interest to the health department. Surveys are really an excellent source of information on things like health insurance coverage or access to care and diagnosis histories for a range of chronic health outcomes, including diabetes, heart disease, depression or anxiety. And also they're useful for getting information on risk factors for chronic diseases such as smoking or alcohol use. Most surveys are done at one point in time, and so they're cross-sectional, and they get at point prevalence. But if you repeat surveys over time, you can use them to monitor trends and changes in the prevalence over time. Again, really powerful because the estimates are representative of the general population, and you can interpret it as such. As an example of uses of survey data, these are data about the prevalence of smoking that come from New York City's Community Health Survey. It's a telephone survey of about 10,000 New Yorkers that the City Health Department conducts every year. And this analysis aims to inform strategies to reduce smoking inequalities. On the graph, they've stratified the outcomes by race, ethnicity, and whether the respondent was born in the US. And they describe how Black and Latino men in the US had higher smoking rates than those born outside of the US. And in contrast, Asian men born outside of the US had higher smoking rates than those born in the US. These data like these can really help inform tailored outreach to specific communities aimed at mitigating the negative impacts of community level factors that contribute to inequities, such as tobacco retailer density, marketing strategies that are targeted towards certain neighborhoods, and systemic racism. Here's another example of data from the New York City Community Health Survey. Here they're focused on some of the questions related to healthcare access and healthcare insurance. On the left side of the graph, you can see the proportion of people who needed healthcare but didn't receive it, stratified by their insurance coverage. There's a gradient here with those having no healthcare insurance coverage, with the orange bar being more likely than other New Yorkers to need care but not receive it. On the right side of the chart, you can also see the association of healthcare insurance with not having a personal doctor. So people without healthcare insurance are much less likely to have a personal doctor. This is useful information that assesses the extent to which there's unmet need outside the healthcare system. It can inform decisions and policies and other actions as it relates to improving healthcare access and access to health insurance. This slide just lists a few examples of different surveys that are out there: health interview surveys, provider-based surveys, and other surveys such as the exam-based NHANES, which is a national population representative survey that includes clinical exams and specimen collections that are tested for different things in laboratory settings. Intersectoral data as a source of public health surveillance information refers to data that are either outside the healthcare sector or data that cut across multiple sectors. Examples of intersectoral sources of data for public health surveillance include the census, tobacco sales information, data sets from law enforcement that monitor the purity of heroin so you can get a sense of overdose risk, gun sales, air quality and heat indices, and weather data. These are all data sources that are really useful for public health surveillance but are not collected for or by the healthcare sector, or the health sector, but they nonetheless can be leveraged for public health surveillance. Here's a great example of intersectoral data that were used quite effectively to make the point about how lead in gasoline was driving high levels of lead in the general population, in the blood of the general population. Red line shows the blood lead levels that were monitored in the US population that came from NHANES, which, as I mentioned earlier, gathers specimens for laboratory testing. In this case, one of the tests they did was for blood lead levels. And it's conducted repeatedly, so that allows for the assessment of trends. And they've overlaid here the trend in blood lead levels with trend information on the amount of lead in gasoline, which comes from other intersectoral data sources that are involved in monitoring the content of gasoline. This is a very influential study that showed essentially the effect of removing lead from gasoline used for cars on the blood lead levels in the population of the US. And just to put these values here into perspective, the CDC eventually set a level of concern for health intervention for children at lead levels of 3.5. And it's since acknowledged that there's really no safe level of lead in the blood of children. So it was a major public health triumph to get the lead removed from gasoline and also paint, by the way, despite having it be counter to commercial interest at the time. And doing so was highly effective at reducing what were essentially ubiquitous elevated blood lead levels in the general population, and it helped avert major outcomes in cognitive impairment and hypertension on a very large scale. And these kinds of data, even though they were collected sort of after the fact that gasoline started to be, or lead started to be removed from gasoline, the importance of documenting this phenomenon made it extremely hard for commercial interests to come back and push to change things and maybe not have to remove as much lead from paint or gasoline. So I think it's a great example of how intersectoral data have been used very effectively combined with public health surveillance. So to wrap up this part of this week's session, we've shown that surveillance systems often rely on multiple, sometimes redundant sources of information. And this can help improve the completeness of case ascertainment and the completeness of information within the surveillance system. Surveillance systems might not always be based on notifiable diseases or events, though, right? Although it's usually the rule for infectious diseases. Surveys can be another useful source of data for non-notifiable conditions and for getting hard to get information about risk factors that might not otherwise be available from healthcare providers or laboratories, for example. Surveillance systems can often have limitations, though, around timeliness, accuracy, and completeness. For surveillance systems to be most useful, you really do need to understand their limitations thoroughly. Indeed, a lot of what this course is about is giving you the tools to assess the strengths and limitations of surveillance systems so you can gain insights to help you really understand how they can be used most effectively. And we'll have more in-depth examples of some of these data sources to come later in the course.